Hello, everyone. Can you hear me okay? Okay, I think I have to do the eat the mic thing. How are you all doing? First of all, I just want to say welcome to all of you. Thank you so much for coming to this big welcome back event. You know, one of the reasons why we're doing this event is not just to welcome our new students, our returning students, our returning faculty and our new faculty and staff, but we really are doing this as part of a larger effort within our school to rebuild our community. You know, I think as many of you probably know, the years of COVID-19, the years of being remote, many of you probably had your undergraduate education, maybe even some high school education, um, online. Um, our building has uh, become a little bit emptier because of that. People have gotten used to sort of the new way of work life, something that we are trying to adjust to. But in the meanwhile, what we don't want to lose is what we had prior to the pandemic, and that is a close-knit community of individuals who not just enjoy being in this building, but enjoy being around the people who you're working with and who are colleagues with and who you see in your classrooms. These connections that you build in your classroom or in your workplace are connections that last for the rest of your life. You know, these are the people who are going to be at least your Facebook friends 20 years from now, right? You know, I don't know about calling them up and stuff, but they'll at least be on your Facebook in your Facebook friends, or maybe Instagram, whatever it is nowadays. But these are important, these are important relationships. And you build these relationships not just by sitting in the same room together, but by interacting with each other in the hallways, by having fun together, by doing out of class projects, uh, hanging out on the Ave, having lunch between your classes, or even just hanging out in front of the building on your class breaks. It's when a lot of the networking happens. That's where a lot of the magic happens. That's how you build relationships. That's how you build community. So it's one of the things why we're doing this today. And I really want to welcome all of you and thank you all for being here. Um, I do want to acknowledge that we stand on the lands of the Coast Salish people. I also live and work on these lands, and I want to express my honor to those people past and present. And then finally, I just want to talk a little bit about some of the things that I guess are on the top of our school's mind as we move forward in this new year. So one of the number one priorities that sort of has come forward since I've been dean, and some of you know, this is just my second year. I just started last year as my first year as dean. But one of the number one priorities, like I said, has been this idea of community building and the impetus for these events and for building the culture of well-being and a culture of excellence. Second, in terms of our priorities, has been infrastructure. You know, like many of our budgets at home, costs are kind of outpacing revenues. You know, we're spending more money than we can bring in because costs go up and wages kind of stay static. You know, in some ways, and it's also hitting our school in terms of costs. We will keep our commitment, keeping tuition as low as possible. We'll do everything we can to reduce the student income to debt ratio, and we've made major progress in some of these areas, and we still need to do more. We still need to do more. I would love it if one day every student of ours could walk out not only with a degree, but with no debt, and that's something that will take a lot of work in terms of fundraising, in terms of, really getting people to understand the importance of social work within our society. Um, and I'm up to the task. And then finally, infrastructure to provide the necessary services to our faculty and to our students. All of you all deserve the best. You deserve to be supported in this journey. We don't want anybody here to feel like they're alone. We don't want anyone here to feel like they don't have a place here, that they're not welcome. We want to do the things that we can do to support you, to make sure that you feel welcome so that you can be the best person you can be. Reach your full potential. And we've already seen great success in both of these areas. We've made some progress. We have a long way to go. one of the next steps forward for us is we're developing a strategic plan. And this year, you're going to probably be hearing a little bit more of that. Last year, we did get some input from our faculty and our staff. This year, we're going to be focusing a little bit more on trying to get some feedback from our students as well as our alumni. So I really encourage you, when you see those emails, to please consider participating in the strategic plan. We need your voices, and we want to hear from all of you in terms of the future direction of the school. So yes, look out for an email. The facilitators of our strategic plan is an organization called Point B Strategies. And just so that you folks know, I want to read you their mission statement so you know what kind of organization this is, because Point B sounds like, what kind of organization is this? Seems a little too formal. Well, the mission of Point B Strategies is to partner with communities, organizations, and leaders to disrupt the social sector and to design and implement more inclusive and equitable spaces, systems, and practices. They're staffed by social workers and also female-owned, as well as LGBTQ-owned. So wonderful organization that we're working with, and they've been wonderful so far. And we hope that they'll continue to get us good information. And then finally, the last thing I wanted to share with you about is about something that we're going to be kicking off on November the 1st, which is an event for the Grand Challenges. Okay, some of you may have heard of the Grand Challenges, some of you may have not. But about 10 years ago, we started the Grand Challenges, but actually it occurred happening prior to that. And it was actually our former dean, Edwina Uehara, who was one of the masterminds, I don't know what the word is, but one of the strategists behind the development of the Grand Challenges, and wrote one of the seminal papers to introduce the Grand Challenges to the field. And essentially, these are 14 challenges, so 14 social problems that the field of social work would like to make an impact on within a 10-year time period. So we've had our first 10 years. We're going into our second phase of our Grand Challenges. And to sort of celebrate the 10th anniversary of the Grand Challenges, we're having a kickoff event on November the 1st. So keep a lookout for that. And for students, we actually have something that we hope that you will enjoy. What we will have is a student design project. And the student design project is a collaborative opportunity for social work students to work together on projects addressing the Grand Challenges for social work. Teams, minimum of 3, okay, can submit proposals that relate to community outreach, research, policy advocacy, and/or student engagement. And selected proposals will receive funding for their work, up to $500 for their selected projects. The project proposals will be due in January, and you'll have until the end of the year to implement them. So I want to invite those of you to start thinking of it. Many of you may already be involved in some pretty cool efforts that you want to amplify or partner with communities. One of the things that we are asking our student groups to do is, when you form those groups of 3, to find a faculty and staff person to help you, okay? Because sometimes it's really useful just to have somebody on the inside who can say, oh, do it this way versus that way. You know, they can give you some advice. But more importantly, I think just so that we have a contact for all of you, so we know how to reach you, we know, who to sort of speak with, and that we know that you're being supported as part of this effort and you're not just winging it. We want people to be successful in that effort and make an impact. I know it's not a lot of money, but you can make I've made impact with $500 before. You can do it. That's pretty much it. I do want a presence, that, within our university, we're having really a lot of challenges with what's happening in the Middle East and the really the disastrous outcomes that we're seeing. And, I just want to say to our student group that our students, as well as our faculty and our staff, that, we really want to stand with you and support you in whatever efforts that you want to pursue. One of the things that we don't want to do is to stifle anybody's freedom of speech. And we want people to be safe. Okay, we want to create a safe environment, not just for people on one side of the argument, but people on both sides of the argument. I'm everybody's dean. I'm not one group's dean. But that being said, it doesn't mean I can't support you, right? I can support you in many different ways. Um, Focusing on things we can't do is less productive than focusing on things we can do together to be great and make an impact. So I really, I'm very grateful to have the opportunity to not only be in this position, but to be able to hopefully open up dialogue with those of us in the school who, um, want to do something about what's happening and maybe don't know how to go about doing it. Um, we can support you. We can help you. We can find ways to uh, help you to accomplish your goals and not commit crimes or not engage in too many behaviors that'll get a lot of people in trouble and things of that nature. There's definitely things we can do to really be supportive of all of you. So I just want to say that that's unscripted. That really just comes from my heart, and I want you to know that we're here for you, and not just me, but everybody. Everybody's here for you. All right. So with that, we're gonna have some fun now. Is that all right? It's okay to have some fun? Okay. I'm going to turn the floor over to Janae, and we will be sharing with you a little bit about what the rest of our afternoon is going to look like.
Hi everyone. This is not planned. I'm sorry. But my name is Janae Carpio, and I am the Assistant Director for Student Services. I'm also in the planning committee for this beautiful event today. I just wanted to let you all know of what's happening around the building. We have 3 floors. We're not including the basement this time. We have the Dean's Welcome going on right now, and after we also have the faculty research talks down at the Commons, research Commons from 5 to 6. So we have at least 5 faculty research that are going to be presenting for 10 minutes, I believe, each. And on the first floor where most of you were, we have the food. And hope you all go back for seconds or thirds. We also have the student and employee organization tables. Student groups are there as well. We have the check-in table. So if you haven't yet, please feel free to go there and make a name tag. And also we have the scavenger hunt happening. It's more like a get to know the building. But at the end, if you complete that, you get an all-exclusive School of Social Work hydro flask. So it's pretty big. Yeah, we don't get that swag all the time. So please please try to work in groups. You could do groups, you could do individually, but it's a tour of the building. And then on ground floor, suite 23, we have the admissions meet and greet. And it's we have snacks, we have sweet treats and popcorn. So if y'all are not feeling the healthy food on the first floor, it's almost Halloween. Treat yourselves down there. We also have a photo booth there. And we have a special guest coming at 5:30, Harry the Husky. So we made an almost impossible possible by getting him here. Please hang in, and hang around, and you'll just see a 4-legged dog walking on 2 feet. And that's him. So thank you all for being here. We appreciate you all sharing the space with us today. Yes, north end of the second floor. Thank you.
Anybody's planning.
Hi, everyone. We're in the Research Commons here, so please feel free to come on down. We have Gino Eisenberg, Megan Moore, David Hu, Rona Levy, Margaret Kuklinski and Denise Walker coming, so we'd love to see you.
All right. All right. This room is live.
Hi, everyone. I want to thank you for coming. My name is Vicki Anderson-Ellis. I'm the Assistant Dean of Finance and Administration and part of the Planning Committee. Welcome to the Research Commons. If you have not been in this room, this is our IP classroom. It is brand new. It is state of the art. We are putting health science education building to shame by being here, which is nice. And as a result of it, we wanted to showcase our faculty, the great research they do. And part of what we've had this year with the dean's speech is really his goal is living our passion, and how do we do that? And so we really wanted to showcase our faculty, some of our faculty, and especially for students in this room to get to know who the faculty are and what they do. And so feel free to come on in. And so we have 6 people that are gonna be talking for 10 minutes. So it's almost mini TED Talks. And what we've asked our faculty to think about are the following questions. First to describe who they are in their research, what motivates them in this research, why did they pursue this research, and what type of impact has the research had to date, and where do they hope to achieve that going forward? So no pressure. And Alyssa Camp, who is our Director of Research Operations, is going to be our timekeeper, so that way we can keep it on task. And feel free just to listen. We are streaming this as well, so that way people, if they're remote, they can listen in. And with that, I'm going to introduce Megan Moore, Associate Professor. So you are our first.
Is it okay to be back here? Or
Yes.
Okay.
I have no
Just like
idea
on
where
one
the
side.
things are.
See from every direction. Okay, thank you. And I'm not trying to make this formal with slides. I just gave a talk yesterday, so I had some handy. And I kind of think it's nice that see visual. So I am Megan Moore. I'm a faculty member here, and the pictures here are where so this is where I trained. That's called Haviland Hall at UC Berkeley, and then this is at the Zuckerberg San Francisco General Hospital, so that's where I learned to be a social worker and to do research. And then this is where I trained clinically to be a social worker, a hospital social worker. And at the hospital, I trained and worked particularly with patients and families who had a traumatic brain injury. So that's been where my work has been focused ever since. And my goal and what I've been working on, as I reflected on this talk and the one I gave yesterday, that's been over 20 years I've been doing this. So I started Berkeley in 2004. So I'll tell you a little bit about, so my goal for this is to get you all excited and to get you to come work with us and be part of our programs that we have here at UW. So for context for where I'm situated now and where my work is now is at Harborview Medical Center, which is our regional trauma center here in the Northwest. It's a level 1 trauma center. Mission-driven hospital, there it is pictured there. And we've been doing work in injury, people have been doing work in injury and violence prevention for many years there. And all the work that I do, so our injury center, we focus on all kinds of injury and all kinds of, across the continuum of care and in prevention as well. My work, as I said, has been focused on traumatic brain injury, and my work is community engaged, patient-centered. So a lot of our center just received a new grant, and that is the focus of our next 5 years, is to train scholars, advocates, social workers, others in community engaged research and work and advocacy in the community. So pretty exciting. So this is our vision we call it HIPRC's terrible acronym, Harborview Injury Prevention Research Center, HIPRC. So this is our vision. So together, and by together, I mean all of us, all of our community partners, those with lived experience, those most impacted by injury and violence, and those of us working in a hospital setting, we have the power to prevent injury and violence. That's what drives our work. And then just to give a flavor of some of the selected impacts, these are not things that I have necessarily been involved in, but the center has. This is interesting. When I was putting this together, thinking about some of these things, you just think about as they're just part of everyday life now. But there's a lot of research at UW and other places that have gone into influencing national highway speed limits and car safety. So how cars are made today to prevent serious injury and crashes, bicycle helmet laws, child passenger restraint laws, distracted driving legislation, which is relatively new compared to some of those others. And that's a lot of that work was done here at UW. Apartment window guards to prevent falls, smoke detectors, fire retardant pajamas, school violence prevention programs, concussion education and guidelines. So for those of you that played sports or have kids that play sports, now it's pretty ubiquitous that we have concussion guidelines for return to play. That's a lot of that work was done here at Harborview and elsewhere. We also have guidelines now for returning to school that were influenced by some of the work that we did. And then drowning prevention, which is a huge issue in Washington State, as you all know. We have many bodies of water. So every year we just finished our campaigns in the community outreach and education arm of our center to support communities in drowning prevention work. And then, so these are some of the areas that we work in, and we're really focused on the social and structural determinants of injury and violence, and also the social and structural determinants of outcomes. So thinking about equity and disparities, what drives that? And we do that through community engaged research, kind of, and across the continuum of care from pre-hospital and emergency to acute care and then rehabilitation. So pictured here, some of the staff, and then on the left on the top, that's one of the founding members of the center, Fred Rivera, who has a connection to our school as well, and the chief of trauma there at Harborview, Eileen Bolger. So some of the critical gaps, and I thought I updated them, but anyways, the point of this slide, so there are known disparities in injury, both risk, so who's at risk for certain types of injury, and also across the continuum of care in terms of types of care people get and then outcomes, because all of that affects your trajectory towards your outcomes. So some of the critical gaps that we try to address that lead to those disparities are data limitations. So we don't collect good demographic data in terms of like nuanced data, right? We collect these sort of large categories. We also don't collect long-term functional outcomes for injury patients. And so it just really limits our ability to track and see what's happening and intervene. Uncoordinated systems of care, anyone who is in this room to tell you that, that's part of why we are all here to help with help patients and families navigate those systems. And we try to work also at the meso and even like macro level to coordinate the systems, not just, you know, at the micro level, helping patients in the hospital. And then policies and payment structures that really disincentivize services for people with public insurance, frankly. And that's where some of the policies and payment structures need to be changed, because there's just limited interventions that are culturally resonant or patient-centered, limited training for providers in trauma-informed care. And I'm not talking about the individual level, like at the higher level, and then limited services. So particularly when you kind of drill down into insurance type, just dismal availability of services. So those are some of the things that we're working on. And I'm not going to go into details, but just to give you a flavor of some of the work that I've been doing. So this is a study of patient-centered intervention. It's a social work intervention for people with like moderate to severe traumatic brain injury, transitioning from acute care to outpatient care. So we don't have the outcome paper is not done yet, but we did do a satisfaction survey, and patients and families were highly satisfied. It's a huge study. So 6 centers across the country, 1,000 patients and caregivers. They were really, and one of the things that I found interesting, it's supposed to be a case management intervention, but what families and caregivers told us that they really liked about the intervention was the clinical work. So the emotional support, the connection, the relationship with the social worker. And I just thought that really kind of resonates with, I think, our experience as social workers. So that's what we heard from them, and we'll see about the outcomes. The other thing that's what I think is really interesting about and fun about this study is that we created with our patient partners. So we have patients and families with lived experience that work with us on the study and are really part of the team. So we created with them these videos that are readily accessible. This is the TBI Model Systems website here at UW. They have videos that were led by our patient and family caregiver and people with lived experience about their experience working with researchers. So it's really to train researchers to understand how to work with people who have cognitive disability on the research side. So we think that's kind of cool. And it's accessible, hopefully. So this is another study. Should I admit this? Oh, I don't think I can. I don't see someone's waiting. But this is another study. This is that we're just underway. It's a year in. This is a Department of Defense funded study serving military service and veterans with traumatic brain injury, trying to improve their access to care. This is our group, and this is Leslie's here, who's part of our group. And these are some over there. It's based out of Tampa, Florida. That's there's a big VA there. And so we are working with them to improve both for military service and veterans, their access to care within the system, and then we're hoping a lot of what we learn will be applicable to civilian contexts as well. And that's a very engaged study, meaning the military service members and veterans were involved in designing the study. So they're partners that we've had for years. And then they're involved in as when we got the study and setting it up and every part of the study. So we just had a meeting today with that group, and they've been affected by the storm too. Okay, so the community outreach and education is the other arm of the center. So we do a lot. We're guided by our community advisory board, some of whom are pictured on the bottom there. And actually my kids who are here were at this event. Do you guys remember that event that we went to? So that was a drowning prevention. We were doing drowning prevention education in the community, and I think the top one as well. So we're really thinking about expanding these outreach and education events. And we really rely on our community advisory board to guide what people want to hear about and what are the injury prevention or like injury worries in the community, and what can we do to support that. And then training pathways, this is the part that I want you all to hopefully get excited about. We have training pathways. We have high school, undergraduate, graduate, and also postdoctoral fellow training programs. We're trying to increase the master and undergraduate presence, master student and undergraduate presence and graduate student at the center. So we have I just want to plug one thing. Every Wednesday we have a meeting at 1 o'clock, which you'd all be welcome to join our listserv. We have methods talks, we have a speaker series where we bring speakers from across the country. We also have a journal club, and then we have like a work in progress. So if somebody has an idea they want to share, get feedback from others who are working in the space, that we have a collaborative space for that. And so would just love to see more of you all in social work there represented. This is our undergraduate program. Every summer we bring out undergrads from across the country. They do a mentored research program, and they're just phenomenal. And we've had like over 800 applications this year for it. It's like for 20 spots. It's crazy. And then we connect our high schoolers with the undergrads and other levels to get them excited about healthcare careers, research, public health, social work. So these are some of the posters. Those are actually high school student posters, which is like amazing the work that they did. And then they collaborated on these infographics with the undergraduates for drowning prevention over the summer. Okay, I'll stop. But so future directions, this next cycle, which is we just started in August, our grant, we're going to be focusing on rural drug overdose prevention, preventing adverse childhood experiences, school safety and violence prevention, and preventing falls with our tribal elders. So come join us. Oh, and I forced the kids to come here. So there's Paige and Dylan so to all you workers, it's to you, and you're all here, bring your kids. We're a friendly space for you all. So that's it.
Thank you, Megan. Thank you, Megan. Mini TED Talk number 2. We're just going to go rapid fire here. We have Gino Eisenberg, and he's from Latino Center for Health, and he's here to talk about the study.
So welcome, everyone. I'm Gino Eisenberg. I'm a Mexican Jew born and raised in South Central Los Angeles, an African-American community. I co-direct with Dr. Leo Morales, Latino Center for Health. If you're interested in research opportunities, scholarship opportunities, practicum experiences, please contact me. I'm not talking so much about the activities of the center. We're following the guides. I'll share a little bit about my story and how I got to do what I'm doing today. So I'm using some notes because I had a busy day, presentations with colleagues in Mexico City, as well as a presentation to the Community Health Plan of Washington and another meeting. So my brain is a little bit fried, but my research is really grounded in a desire to connect in partnership, authentic partnership with community organizations, bringing resources to bear to impact positive change and promote health and well-being. I mentioned I was born and raised in South Central Los Angeles. I was a resident during the tanks going along Lawrence Avenue. During the Watts riots, I was a resident when the verdict was announced of the beating of the police officers, released non-guilty verdict regarding beating of Rodney King. And researchers flocked to my community getting their data and left. And I was just incensed because their questions, however meaningful, were not deep enough to bring about change for my community. And so I had no aspiration to get more initials after my name, but I decided I needed to get a doctorate degree to talk to the research community and scientists. So that motivated me to bring the voice of the community to the table of the research community. My research, when I came with my family 22 years ago, after 6 weeks, I went to the Yakima Valley to visit mental health provider organizations in the Yakima Valley region. And the last stop was at the Yakima Valley Farm Workers Clinic. And the director of planning and budget said, Gino, I'm so glad. I'm a graduate of the School of Nursing at UW and the School of Public Health, but we do not welcome UW researchers because they pop in and they popped out, leaving no tangible benefit for our organization or the residents of our community. I said, I'm not here to do research. I'm here to listen and learn. And selfishly, I want to get some sunshine. Okay. So that first year, every 6 weeks, I just drove over there and do the same little loop. But in that, I was building a sense of trust. They saw my face. They got to get to know me. And over time, the Farm Workers Clinic said, Gino, can you help with Scott Hengler's multisystemic therapy intervention for adjudicated Latinx youth? Okay. We're asked to make cultural adaptations. Are you able to help with Los Niños Bien Educados program, in which it's sort of akin to Head Start program and training? And then finally, in 2007, they said, Gino, 50% of our patients do not follow treatment protocol for depression. Can you help? And so with colleagues that I knew from psychiatry, Dr. Megan Dwight Johnson, Yvette Ludman, then of Group Health, now Kaiser, we offered the opportunity to revise the manual that Yvette and Greg Simon, her colleague at Group Health, had implemented for patients of Group Health at Capitol Hill, English speaking, insured, urban, middle to upper middle class. And this is going to go to Spanish speaking, rural, low income, highly stressed or multi-stress population. So, and the intervention is 8 sessions, 45 minutes of cognitive behavioral therapy. It's manualized and it's all delivered by phone. And so I didn't have strong belief that this is going to work, but actually it worked very, very well. Not only from a patient side, they didn't consider themselves in the stigma of being in therapy. They saw themselves in la clase de depresión, depression class. They had the manual. They reviewed it each session with the master level clinician. But it was funded by the National Institute of Mental Health. They said, you already showed in this small randomized clinical trial of 51 participants, you don't have to do another larger scale clinical trial. And we go, no. So it took a couple of years, but then we recognized there was a resource in the Yakima Valley, and that's Heritage University, a small private university, Native American, Hispanic serving institution. And I said, you have a bachelor's of social work program. Why not see, since there's a scarcity of bilingual, bicultural practitioners, why not train bachelor level students and see if they could effectively deliver this one intervention and provide the requisite supervision. We trained 4 cohorts, provided stipend. It was over and beyond their normal coursework. After the training, they delivered the intervention to patients of the Farm Workers Clinic, who loved it because it reduced the wait time of their patients to receive depression care. They were very, very effective, as effective as the master level practitioners. We received then a grant from Molina Health Foundation to train paraprofessionals, staff members of the Farm Workers Clinic and CMAR at the bachelor's level or less in the same intervention. And now we're concluding the supervision. We've done the training program of 5 promotoras and their supervisor. in Beaverton, Oregon, near Portland. So they're delivering it all in Spanish. And they're a great group. And then I presented in Portland in April at a small conference of researchers, and people came up to me and said, I want to contact you. Good, good, good. Well, this woman said, I'm going to contact you. I said, okay, fine. Well, she did, and on her signature, she's the program officer of NIH in terms of cancer. I said, oh, this is just different. She put me in touch with the colleagues of hers in Mexico City. She encouraged us to submit a grant proposal, which we're in the process of preparing. I'll be visiting Mexico City the week of November 18th at their Institute of Cancer. We're going to train undergraduate students of psychology and social work. They're going to be delivering the manualized intervention, 8 sessions by telephone. And what, in addition, we're revising the manual to reflect stories. It's a different population. They call young adults 17 to 39. I don't consider that to be young adult, but that's what they consider. And so who were recently diagnosed with cancer, multiple forms. So lo and behold, it isn't just Mexico. It will be Chile. It will be also either Honduras or Guatemala. It's a 5-year grant, and we're very, very excited. We're very excited for the intervention on that side. The international countries get 70% of the funds. I'm excited on this side because we get to have students be part of the project and learn and train and have that interaction. We can do this by phone. I'll be going several times a year over to the different countries to get FaceTime like I did with the Yakima Valley Farm Workers Clinic. What is really important is that all this effort isn't just about depression intervention, which is impacting. We're also shifting the paradigm with regards to workforce development. Our schools, whether it's social work, psychology, psychiatry, medicine, we're not producing enough providers, practitioners. This is creating a whole new access. And now we're requesting funds from the state legislature to actually address community college graduates, provide funding scholarships for them in partnership with their deans so that they can continue their education rather than simply be technicians such as x-ray technicians or phlebotomists or such technical. We want them to continue to believe and pursue higher education to be the dentist, to be the pharmacist, to be the physician, to be the licensed clinical social worker. So I'll conclude with, in the words of Dolores Huerta, sí se puede. Yes, we can. We are increasing the workforce of Latinx individuals to deliver evidence-based and culturally responsive depression care. And we're just very, very grateful for those opportunities. Thank you. And I have another meeting to go to.
Now, next up on our mini TED Talk, we have Dr. Margaret Kuplinski, who is the Executive Director of the Social Development Research Group.
All right. Hi, everybody. I want to begin with just a little pulse check. How many people here are MSW students? Okay. How about undergrads and doctoral students? All right, we have it all. I am Margaret Kuplinski, and I think the theme of this 10-minute talk is passion. And the place I want to begin is telling you a little bit about me, and I will start by saying that passion is not all about work. Outside of work, I'm a wife and partner of 38 years. I can't believe I can say that. I'm a mother of 2 adult children who don't live nearby. My empty nest has become fuller because I have a large 9-month-old golden retriever puppy who is exuberant and a lot of fun. I love to hike, I love to cook. So that's one of the things I wanted to share. Another is that I joined the faculty later in life than I imagined any of the faculty in this room did. I became a faculty member in my 50s. And that was in part because I was exploring some other possible passions first. So I started in economic consulting after college. That was not my passion. So I then did something that I really loved. I spent some time in pastry school and I worked in a restaurant for a little bit. That was great. That was an avocation, but it didn't encompass as much of me in my professional life as I wanted to. So I then went to graduate school in clinical and community psychology. And eventually I became a member of the UW, not faculty first, but staff. And 10 years ago, I would never have thought that I'd be standing here today as a faculty member. But with mentoring and support and an attitude of, I'm going to dive in and try it, and I'm going to work hard, there are a lot of things that are possible. And so that's what helped me get to this point. And let me shift now to maybe what we really were supposed to talk about, which is our research. And I wanted to begin that with, I really love what I do. I am never bored. Sometimes I say I love what I do and there's a lot of it, but I'm an associate professor, so I teach and mentor. I also do research, but that part comes primarily through my role as the director of the Social Development Research Group. Let me say that again, Social Development Research Group, or lovingly SDRG. Have any of you heard about SDRG? Maybe not. Okay, well, we are a research institute. I think that's the best way to think of us. We've been part of the School of Social Work for 45 years now. And every research center has a focus. You heard about Dr. Eisenberg's a little bit, and Megan Moore's, I guess she left too. Ours is focused on prevention and health promotion of behavioral health outcomes. So by behavioral health, I'm talking about mental health, substance use, and also what I'd encompass as externalizing behaviors, things like violence. So we are not on the treatment end. We're trying to make sure that those issues never come about in the first place. Or we're trying to promote good outcomes, mental health and well-being. So at SDRG, our work spans the continuum from research to practice. We've got folks who are thinking a lot about the root causes of those behavioral health outcomes and researching that through large NIH-funded trials. We've got another group of folks who collect data. And my way of thinking about that is the foundation for scientific discoveries. They're amazing at what they do. And then the third part is our practice arm. That's the Center for CTC, and it's where we're trying to take what we've learned through science out in the world to make a difference. And a lot of what we do when we do that is work out in the community, engaging communities around their own prevention and health promotion goals, and supporting them in getting there with the communities that care framework. And that's a framework that's been shown to improve substance use, violence, delinquency, handgun carrying, crime, lots of things. And we again get at that by going upstream, working on those structural drivers, also those environmental drivers, those interpersonal drivers, social ecological, that affect those outcomes. So that's what I do. There is a lot of it. I'm supporting a group of about 35 researchers in, not just researchers, but researchers, data collectors, practitioners, in doing that work. It is never dull. How did I get there? Well, about 15 years ago, I was looking for a job, and David Hawkins, who was, I don't know if he was the director at the time, but he was one of the leaders of SDRG, wanted me, knowing that I had an economics background and clinical and community psychology background, to do a benefit cost analysis of this communities that care intervention that was starting to show benefits to human lives. And that task was to understand the costs of delivering that intervention, communities that care, and compare those costs to the benefits that would follow from these better health outcomes and see if the benefits outweigh the costs. And I think I mentioned that I was an economist and also a clinical and community psychologist. And this was a way to bring my worlds together in a way that I never had imagined. And so I really did feel like a kid in a candy store getting to, pull on these pieces that were both of interest to me not in economic consulting, which didn't do it for me, but around this work that was ultimately meant to lead to better developmental outcomes for young people. And so I was hooked on that. And then there was one other piece of the work that really drew me in. And that's that the interventions that SDRG has focused on are really a huge part of them is about building connection. So I'm sure you've all read, heard how important positive bonds and connection are to health, happiness, well-being over a lifetime. And those connections, we want them to come from the family, but they don't always. And the interventions that SDRG has worked on tap into a broader set of connections and fostering those to help young people thrive wherever those positive connections might come from. And that was really appealing to me personally. So hopefully I've given a sense of the pieces that are core to SDRG's work: prevention, health promotion, behavioral health, a little bit of health economics around costs and benefits and things like that. But I want to just shift gears before my time runs out to the impact of the work that we do. And I think there's a lot of impact. I'm going to focus here on some things that are personally meaningful to me that I've been involved in. And some of them are a little headier, some of them are a little more human. But on the headier side, it has to do with the health economics work. 2 minutes, I can get there. I've been involved in efforts to set standards to make sure that health economics work is done in a quality way. And I've been involved in a couple of national committees to do that. And it's been really great to know people across the country and also to try to make an impact at that broader level. One other impact on the human side, and I'll wrap it up with this, is that we're involved in a project right now to support caregivers who are affected by opioid use disorder in Washington State. And we're supporting their recovery by bringing evidence-based parenting programs to them in a variety of settings in which they're receiving those treatment services. And we've reached 300 families through this work. And we've recently learned from data that we're collecting that 90% of the caregivers that we've served and who have provided data would recommend those parenting programs to others in the recovery process. And they also say about 2/3 to 3/4 of them say that that parenting support has fostered their recovery. So that, I don't know, at least to me, it doesn't really get much better than that. So I'll end on that note. If you're interested in learning more about SDRG, you can go on the website and find ways to reach me. Please reach out if you are. We have an MSW student with us now. We love working with students in a variety of ways. And I'm so glad you're here today. And thank you for giving me the floor for about 10 minutes.
Next up, we have Dr. David Hu, who is part of the Digital Wellness Research Institute.
Good evening. Need a moment to switch gears. Okay.
Take all your time.
Well, good evening, everyone. I'm David Hu. I'm a research assistant professor, also director of the Methods Division at the Indigenous Wellness Research Institute, which is just across the room on the other side of the Research Commons. So I'll speak briefly about the ERI, as we affectionately call it. It's one of my greatest joys is collaborating with a wonderful group of researchers that are focused on promoting health and wellness in Indigenous communities. A lot of our work is community-based, actually all of it in some way is community-based. We're really looking at what the needs of the community are in terms of health, wellness. We do a lot of prevention work in the realms of mental health, physical health, diabetes prevention, cardiovascular disease prevention are just a few of the areas we've worked in. We also do a lot of training. So we have multiple training grants, R25 NIH funded training grants. We're always mentoring and open to mentoring new students at all levels. In terms of your projects and your interests. So of course, the work that we do is necessarily sort of grounded in working with Indigenous and Native populations, But as we see in sort of the social work context, all of our work is very interdisciplinary. There are a lot of linkages between one population and another, and that's one of the exciting parts of being both broadly in the world of social work, but also specifically in this department, is that there are very many opportunities. So I'll talk a little bit about sort of what I do specifically. So I'm a clinical psychologist and quantitative psychologist by training. A lot of my work is sort of generally around the area of behavioral health intervention and the linkages with a number of areas from chronic disease prevention, HIV/AIDS, diabetes. I also do a lot of work with substance use, alcohol abuse prevention. A lot of these areas have these interconnections. And I find, as Dr. Kuklinski was just describing her trajectory over time, I could definitely connect with that idea of not having that sense initially of where I'd be ending up. Like we sort of retrace backwards in time. That kind of makes sense after, we live that story. But for me, like I did not know that I would be sort of starting, for example, in my graduate studies doing HIV-related work, migrating in my postdoctoral work to more alcohol use intervention, alcohol prevention research, and also more recently into a lot more quantitative research. So all of those things kind of in hindsight make sense in a way, but I think one of those things that I want to, I guess, express right now is that I did not have a clear idea of where I would end up. And for me, that's one of the joys, is kind of not knowing necessarily, but also over the course of time, thinking about that theme of passions. I think we're always well served if whatever we're doing at the time, even if we don't have necessarily a sense of what the end point is, that we approach it with passion. And then if we approach it with passion, over time, those pieces will make sense. And if we're doing work that we find meaningful and we can work with wonderful collaborators, I think those are a lot of the ingredients to living sort of a fulfilling life personally, but also developing yourself in a career that's also fulfilling in a professional sense. So in terms of the research that I do, a lot of it is, as I mentioned, behavioral health intervention. Over time, I've really developed a particular interest in the methodology that we use to support the work that we do. So, and this is where I think being in the world of social work, social welfare, but just social sciences in general, increasingly over time, it's become much more interdisciplinary. So as a clinical psychologist, I feel very at home in this department because there are other clinical psychologists like Denise Walker, who will be speaking in a little bit. But a lot of the work that we do has all these common threads. So what's exciting about engaging someone for me with the particular hats that I've developed over time is that a lot of the work, we have these common interests, whether it's in HIV, AIDS, substance use, whatever area, that it all comes together, and those unique perspectives. And it's not just a perspective professionally, but it's also your life perspectives, it's your cultural perspective. I bring a background as a second generation Taiwanese American. That's informed the way that I approach the research that I engage in and collaborate with wonderful colleagues at times those groups that are related to my own background, and other times groups that I feel that I'm entering in from as an outsider, but having the opportunity to work in that space and to enter and have those conversations in that space is really fantastic. In terms of the methodology, a lot of sort of the particular work that I do is about how do we improve the types of methodologies that we use to test our science. So for instance, if we're interested in intervention for preventing substance abuse or alcohol misuse or substance misuse, well, we have all this data at the end of the day. Like, what do we do with it? And that's where, over time, these collaborations have been incredibly rewarding in terms of seeing where the opportunities are within the work to say, okay, so we have this data. How do we actually, at the end of the day, say whether this particular treatment we're interested in, maybe it was developed recently, maybe it's something that we're adapting for a new situation, is it effective or not? So that's where it has to start. It's the questions, and those questions that come from the community and what's important socially. And then for me, what's been fascinating is doing that deeper dive. Once we ask those questions, then we go about proposing studies, getting some funding for that study, hopefully, and then running an RCT study, observational survey study, all the number of ways that you can research any particular research question, you get a mountain of data, which is great. But then what do you do with it? So over the course of time, what I found, and this isn't just my experience, like the world that we live in produces and is associated with very interesting and particularly challenging data. It looks like Swiss cheese. The outcomes are not normally distributed. It's not a perfect bell curve. It's very, very wonky a lot of the times, the data that comes our way. So then what do you do with that data in order to actually answer those questions? So one of my earliest contributions was really about how do we analyze data in the HIV realm? So particularly people in situations where we're looking to support people's adherence to medication. So situation where if you don't take your medication, your life is literally at risk due to a chronic illness that is life-threatening. So one of my earliest contributions was saying, okay, well, we have this data. It's 0 to 100, whether someone's taking their pills all the time or none of the time or somewhere in between. This type of data is completely the opposite of normal classical statistics. So bell curve, it is not. It is W-shaped. You have a lot of folks at either end. So a bunch of folks that don't take the medication at all for whatever reasons. Life is challenging. They may not have stable lifestyles. Some people that they're able to do it with regularity, and then a smattering in the middle. So this actually connects with some of my most recent research. And oftentimes in this career, we find ourselves coming full circle that I started my graduate studies in HIV, and I sort of did this sort of more focus on substance use. And now I'm back to HIV a lot more. What I'm doing now is really developing and looking at methodologies for evaluating this W-shaped or weirdly shaped data to answer the question, well, if you do something, whether it's supporting someone with a technological intervention like text reminders, or giving someone the opportunity to take some version of CBT to address some type of mental health challenge to then help them to support their health in the long term. Okay, so we have these ideas for what might be helpful, but then at the end of the day, what are the things that are actually we want to improve? So in the case of someone living with a chronic illness, it's getting into their treatments, taking their medications. In other cases, it might be their level of depression. But whatever the context, it's, we want to improve their outcomes. So for me, that's been sort of the fundamental aspect of my career that I focused in, which is, how do we evaluate these outcomes that are particularly challenging? So that's one piece. And then the other piece I'll go into briefly is that we also are living in the age of big data. So big data can take a lot of different forms. There's the data that Facebook and Google collects, or Microsoft collects, which is millions upon perhaps billions of data points. In the world of social work, social science, social welfare, it's more, if we can get a couple hundred, that's pretty good. So big data in the social science world is usually maybe thousands of observations. So the type of work that I've been doing the last 5 to 10 years has been more about data pooling. There's different words that you'll see for it, integrative data analysis, meta-analysis using individual participant level data. So those have been more of my methodological contributions recently. It's been developing the ways to both combine sort of challenging data, but also to leverage all those data sources that we have to try and answer some of those questions and basically making the most of all the information that we have out there. If any of you have any interest in methodology, feel free to reach out to me. I'm open to collaborations and mentorship. And I guess what I would encourage all of you is to look at those linkages between your backgrounds, your passions, the things you learn. You have your own expertise areas, and use that expertise and all of that knowledge to inform the work that you do ahead and what you learn.
David, next up on our TED Talk, we have Dr. Denise Walker, who is the Director of the Innovative Programs Research Group. Thank you, Denise.
Have to take up my whole 10 minutes if you don't want, but I was one of those weirdos who knew what they wanted to do when they were little. So I came to UW, I got a degree in psychology, and we needed to do undergrad research, right? So I went into the bottom of Guthrie Hall at the time. I don't know what it looks like now, but I was looking at the research opportunities, and there was one I was like, oh, mothers and infant, like, interactions. That sounds so cool to go out and look at those and investigate that. And so, but my boyfriend at the time was saying, oh, wait, there's alcohol research going on and this guy's awesome. He had imbibed a bit too much in the dorms and had to go to a program in the dorms. And this particular psychologist is the one that gave him his intervention, alcohol intervention. It was so good that he actually wanted me to participate in the research. Well, I didn't get into the mother, child, infant research lab, but the alcohol lab accepted me. And that was how I got my start in substance use treatment outcome research. So I did know what I wanted to do. I wanted to be a psychologist, but I really thought I wanted to do clinical work, right? Forever. Got to grad school and realized that I love clinical work. I still do. But I love the idea of not just impacting individuals, but like really thinking, how do we know what works? How do we improve what works? How do we help more people? So I started basically researching substance use treatments, outcomes, and developing treatments. And in grad school, I worked in alcohol, but also like realized the alcohol literature is pretty huge. There's a lot of outcome studies that you can go and look up, but the drug literature was like way more in its infancy. This is a few years ago. So I started getting more interested in that and did my dissertation was a randomized controlled trial with cocaine and methamphetamine folks. And we looked at, can you help a family member work in treatment with the user as a reward system? And would that work? Like, would that help and improve treatment outcomes? When I did my postdoc, I came back here. I was at University of New Mexico for grad school. I came back here and was doing a postdoc with Mary Larimer, again, kind of an alcohol lab, trying to think, how do I get more involved in treatment, development, evaluation for drugs? And was lucky enough that a faculty member here, Roger Rothman, who's now emeritus, was looking for a clinical director. I joined the Innovative Programs Research Group as a clinical director and am now the director there. IPRG is, fun fact, the birthplace of cannabis treatment, really. So the very first studies for treating cannabis use disorders was here at the University of Washington at IPRG. And I've kind of continued in that work for pretty much my entire career. It was in tiny little literature at the time when I started. We've made a lot of advances in trying to figure out what helps people, how do we attract people into treatment? We know that far majority of people who are suffering from substance use don't enter treatment. So how do you attract those people who are struggling but don't want treatment? How do you do it with adolescents? How do you do it with adults? How do you treat cannabis use disorders when they do want treatment? How do you treat cannabis use disorders when there's comorbid tobacco? Do you offer treatments together? Do you stagger them? And now we're really focusing, myself and another colleague, Ryan Petros, we're focusing on how do you help people who are living with psychosis, young adults with psychosis, change their use of cannabis because it has huge detrimental effects to their outcomes. So IPRG has a few different areas. That's kind of the one big area that is kind of fun. I'm definitely like the cannabis girl. Another kind of approach that we look at is how do you help people change? The far majority of folks are either not coming to treatment because of stigma, because of lack of resources, because whatever, lack of motivation. How do you attract them into services? Maybe they don't even know they have a problem, but they're having questions or concerns. And so we have a whole line of research that has focused on different populations, soldiers who have a substance use problem, but don't feel comfortable coming forward. There's a lot of barriers within the military for seeking treatment. Soldiers, Navy, a lot of active duty military personnel with PTSD. How do you attract them into services to try to help motivate them to access care? We've done it with domestic violence perpetrators. How do you get domestic violence perpetrators to kind of think about their behavior and make different choices? So we've applied this checkup model to cannabis use, alcohol, unsafe sex practices, domestic violence, PTSD, you name it. We've applied this model to basically develop marketing materials in an intervention that attracts voluntary participation from folks who are experiencing problems but not seeking treatment. So that's kind of another area that we're sort of known for. And then our work with military populations in basically the ways that I just described. So I would say impact, like we have developed and evaluated, we have interventions that we've developed in our group that are evidence-based practices and are, listed as the things to do with your clients when they need cannabis disorder treatment or alcohol treatment. And we're kind of continuing to think about how do you apply all of the good theory and ideas and work that social workers and clinical psychologists and all sorts of smart people can do to help people on the ground, right? Help people every day. The best thing I love about my job is that I like the clinical aspect, right? I like to see clients. I like to help them improve themselves and be in that therapeutic process. I love being able to develop interventions and see how can we improve those and figure out what works. But I really love getting money from the government to give treatment that's state of the art away for free. And that I would say is one of the best things ever that I get from my job. I think that's all I want to say today.
Last but certainly not least is Dr. Rona Levy, who's our Associate Dean of Research and the Director of the Behavioral Health.
Everyone, nice to see you. I'm going to start with my Associate Dean for Research hat and just say all of these talks have been amazing, and it's really cool to see all of the things that are happening here. And this is such a tiny fragment of all of the research activities and topics that are going on. So whatever your area of research is or interest, or it's probably something like that is happening here. So I encourage you to look at the list of faculty interests, see what people are doing, follow through on contacting people. We're here because we like working with students. We want to hear from you, so please look people up when you do. Having said that, just a little bit of what you've heard, I think shows that social work, the area of social work is a very big tent. We all kind of got here through different paths. Most of them were accidental. I'll follow up on what Margaret did just a little bit ago. I grew up in Massachusetts. I got my MSW and my PhD at the University of Michigan. And when they were talking to my main advisor and said, "Where's Rona going when she gets out?" The response was, "I don't care, east or west till she hits water," but she's not. I hope nobody here is from the Midwest and takes that badly, but I really want it out of the Midwest. I'll give you the punchline and then explain how I got there. Most of the last many years, I have been studying gastroenterological problems. I know that sounds really weird, and you didn't come into social work to study stomachs and guts, but, and I'll explain why that's relevant to social work in a minute. But how did I get there? Originally, I thought I'd be a physician. And then as I started looking at the medical profession, I realized that so many medical problems that people have are caused and maintained by social and psychological factors. We've heard a little bit about compliance today, and other things that relate to that. For me, the social determinants of health is the hot topic in research these days. How I got specifically to look at stomachs and guts was at the time that I came here, the dean said to me, "We'd really like to further our relationship with the School of Nursing. Would you go over and see if they want to connect with social work?" And I walked in and I met this very brilliant nurse researcher named Margaret Heitkemper and talked about what she was doing. And she was interested in irritable bowel syndrome in women and primarily. And she was basically looking at cell counts in stomachs. And I said, well, I know nothing about cells or stomach linings or anything like that. And I told her what I did, which was I was interested in factors that affected health. And she said, I think we could figure something out and get together. And so we started researching a range of things around what caused women to suffer from this unexplained medical problem. And just a little backdrop, to get a diagnosis of irritable bowel syndrome, there has to be no physical evidence that there's anything going on. So there are a lot of other things going on. There's a much higher rate of childhood sexual abuse and adult abuse in women with IBS. There's family history. There's a whole bunch of things. Not to be confused with IBD, where they're inflammatory bowel disease, where there are known lesions and things. So we started working together, and it doesn't matter whether you're looking at stomachs or you're looking at anything else. You can address the questions you're interested in almost any arena. And so I started looking at all of those things. And as I said, higher rates of abuse, higher rates of depression, higher rates of anxiety. There's a whole range of things that you can look at within this crazy little area of stomach problems. And then I started looking at family intergenerational transmission. And so for the last many years, I've been mostly looking at how parents pass on, if you will, this suffering from one generation to the next, and what are the factors that go into that. And I could go on for hours about social factors, about intergenerational trauma, about a whole range of things. Please come talk to me if you want me to go on about it, but now's not the time. I realize we're supposed to be done by about now. In terms of the impact that we're all asked to address, the question of the impact that we are most proud of and feel the best of. I've been doing this for a while, as anybody who knows me will. And most of my lectures, my presentations, my publications are all in medical journals. And so basically what that means is I'm not preaching to the choir. I am getting up there and I am talking to a room full of, sort of traditional physicians who've gone through medical school and have studied chemistry and biology and all that stuff. And I'm saying, hey, when your patients come into your office, you ought to check out this, this, and this, and you ought to respond to it and be sensitive to it and try to deal with it. And so they hear that. Sometimes those publications have been required reading for physicians going for their certification. So I'm really glad. I mean, they literally had to read it whether they wanted to or not, if they wanted to keep their licenses. And I think, had an impact in the medical field. I hope it has. I was in the early days of the formation of the whole field of behavioral medicine. We have a research group here called the Behavioral Medicine Research Group. I know it's now a little cooler to call it behavioral health, but that's what it was called originally. And that's how we got that name. And I guess that's it. Love to talk to any of you who want to explore this further, but yeah, I would just say things, as I guess other speakers have said before me, things will just kind of fall into your laps, like going over to the School of Nursing, which I had no idea to do. And some of the most exciting opportunities can happen when you do that. So nice meeting you all. I'm really glad you came tonight. Thank you.
Everyone for coming and learning more about it, our wonderful research, our launched website now, which has been some years in the making. There's so much information for all of you to learn more about. And enjoy the rest of the food. And if you haven't done the scavenger hunt yet, please feel free to do so. You got about a half hour. And thank you again. Yes, there's a scavenger hunt. You get free swag. Thank you. Your time is up, wrap it up.
Wondering if it got any more urgent. Wrap it up.
Great job. Vicky was like, bye. She's like.
Nice.
Good.
Yeah.
But yeah, I mean, that is part of the social work aspect, I'm sure.
Yeah, no, I just keep thinking like. Like.
Love to.
Yeah.
So much. Oh, yeah.
Moving forward. I have-
Sure, got to the right people. Sorry.
Wow.
It was a little hard to keep up.
A long time.
Yeah.
Not that I hated it.
She like has a history of financial
Thank
management.
you. I was like looking some.
Right.
So
Minority owned.
I was at the Evans, which is the public policy and
We'll see her around, I think.
I was there for like 19
We were both
years.
with Marianne for the time.
And I've been here for 5. And I'm still in, so I came here and then COVID